my experience, that you can say old, and that's probably true. What I'm going to talk about is advanced MIS and kind of the journey that we took in using that. But that was 40. I've been doing this 40 years. I have a long perspective on the way that medicine has evolved, and I have concerns about the way that that's going. My disclosures: 1001, 1002, 1003. None of these are relevant. So the advanced MIS, first, I think we need to kind of define what we're talking about. Advanced MIS has a lot of different definitions, but for the purpose of this talk, I think we'll just talk about the MIS, the surgery that's done beyond the basic MIS skills that are taught in a general surgery residency as defined by the SCORE curriculum. Some of the advanced MIS would encompass things like bariatric, hernia, foregut, colon and rectal, hepatobiliary, solid organ, thoracic, and robotic. You also have to define community practice. That's been done by the Community Practice Task Force. And I think that it's a good all-encompassing definition. But what just happened? I just had a seizure. But I think that the key point here is where they talk about the community practice surgeons in rural versus the urban centers. And I think that we all have a kind of a concept of how this relationship with the academic centers works. I think probably the academic centers perceive it a little more like this than the rest of us do. But within the context of community practice, we have both rural community and urban communities. And so that's an issue that we have to deal with because there's significant differences between those two. This is where I practice. It's a 25-bed critical access hospital. I've been there 32 years. It's in the middle of Lake Country, Minnesota. It's a beautiful place, at least for 9 months of the year. And the hospital itself has undergone quite a change over those years. This is one of those small rural towns that says, "Welcome to Crosby" on both sides of the sign. In 1987, when I started, I was recruited by Dr. Paul Severson, who has become my partner for all those 32 years, which is remarkable if you think about surgeons and their egos remaining partners for 32 years. But at that time, I was the second surgeon. We had one operating room. We had one CRNA and a handful of OR staff. We did 750 cases a year in that first year that I was there. But that was 1987, and at about that time, Eddie Joe Reddick and William Say took out the first gallbladder laparoscopically, and it all changed. So what we did at that point was we embraced MIS, and we embraced it early. We began giving a lot of public seminars. We did the training. The only course I think that we ever took was how to take out a gallbladder out of a pig laparoscopically using a laser. And that was the rest of it. There was no place else to learn it. There were no other courses for any of these so-called advanced foregut courses. And we couldn't do a lot of that foregut surgery until somebody invented a tool that would allow us to do that. But when those things became available, and we worked with a lot of those companies to help them develop those tools, we started moving into the so-called advanced MIS, and we started doing a lot of foregut surgery, and we did hernias, laparoscopic hernias. We spent a lot of time in the preperitoneal space, hepatobiliary, solid organ, colorectal. We did all of those things in an era when nobody else was really doing them. We established the Minnesota Institute for Minimally Invasive Surgery as a branding tool that's been very successful for us. We did a lot of surgeon training. We had enough expertise that we were able to train surgeons. Surgeons would come to us from a 5-state region for doing some of these courses to teach them to do lap Nissens and those types of things. And we were able to establish ourselves as regional experts, and that's one of the things that MIS, advanced MIS, did for us over that period of time. So today, we have grown from that little one OR hospital to a hospital. We have 7 operating rooms with 2 more in the planning stage. We have 16 in-house surgeons in multiple specialties. We have an accredited fellowship in advanced GI, MIS, bariatrics, and flexible endoscopy. We're the only fellowship, part of the fellowship council that's accredited in all 3 of those areas. We have an accredited bariatric center and an advanced foregut program and reflux and heartburn center that's been very successful for that that little hospital. We also have 2 Da Vinci Xi robots, relatively new at that, but we're learning, and we figure that this is kind of the way that surgery is evolving. And along with the growth of the surgery program, other services in the hospital have also increased, including the number of physicians that are there, including hospitalists and a variety of specialty physicians, emergency department, pathologists, internists, cardiologists, all of those things. So this is what advanced MIS has allowed us to happen in that little 25-bed critical access hospital. And despite all of that, we are still a 25-bed critical access hospital. The first year we did 750 cases in 1987. Last year we did a little less than 8,000 cases during that period of time. The facility revenue kept pace. Our budget when I started there, the annual hospital budget was $8 million. This year the budget is $150 million. So we came to a lot of conclusions along the way as we looked at this, and we found largely that patients are increasingly sophisticated about these advanced surgical procedures. As Dr. Flock mentioned, they will cruise the internet, and if they have some kind of medical problem or a perceived medical problem, they'll work very hard to learn everything they can about it. And then they start looking to find out who is doing those particular procedures. And so you need to be able to, number one, be able to do them, but you need to be able to do them with the same equipment and as well as the referring centers down the road. The patients will drive a long way to get that operation if they perceive that it's going to be higher quality in a different location. We're just 2 hours from the Twin Cities. So they are a competitor. Those hospitals in the Twin Cities are competitors of ours. So the problem that we're seeing, where I want to go with this now, is that increasingly those operations that we do, those advanced MIS operations, require some component of advanced and expensive advanced technology. And, we've found that surgeons are not necessarily going to be able to do the entire breadth of what some of the academic centers are able to do, but we can at least do provide equivalent skills, at least in a smaller repertoire, and that's where we have to strive for that. So we have found that advanced MIS is critical to the success, or at least to the survival even, of community hospitals and to a surgical practice in the community hospitals. The smaller the hospital practice, the more critical it is, and we've all seen the results of hospital closures in rural America all across the country simply because they're unable to actually keep pace with a lot of the technology and the skill acquisitions that's necessary to maintain a successful program. So I think that maintaining an advanced MIS program becomes increasingly important in this career. But the problem is that there's a growing gulf there, and the gulf revolves around resources. There's an increasing demand for those resources, and there's decreasing availability of those resources. And by resources, I'm talking about money. We're talking about staff expertise, physicians, grants, and foundations. We're talking about governmental support. We're seeing that a lot of these things are decreasing, and they're decreasing more rapidly for the community hospitals, and it's widening the gulf between the community hospitals and the academic hospitals. There are a lot of challenges involved in maintaining an advanced MIS program. Hospital resources is just one of them, but there's also things like limited procedure volume, specialized equipment, qualified assistants, OR nurses, techs. A lot of these nurses and techs, they went to nursing school, but they ended up having to be video technicians and engineers in the operating room in order to keep the place running. There's a problem of mentoring. How do you get mentored in some of these advanced surgical techniques? And you also have to have an administration that has a significant tolerance for a prolonged return on investment. So these things are going to be hard to come by, and I think they're getting increasingly hard to come by. The reason I think that is because if you look at medical knowledge, and again, that 40-year span of my career gives me a perspective on this. It's really kind of frightening when you think that in 1950, the doubling time for medical knowledge was about 50 years. 1980, it was 7 years. 2010, 3.5 years. And in 2020, it's projected to be about 73 days. This is exponentially increasing the understanding of applied physiology. That translates to an increasing variety of surgical techniques, and that translates to the increasingly advanced technology that's necessary to support them. So several questions come to mind. So how do you maintain an advanced MIS program when our understanding of surgical disease states is doubling every 73 days? What does that imply for the advances of surgical technology? In turn, what does that imply for a given healthcare system's ability to afford that technology? And are the community surgical practices going to be able to match the pace of technology acquisition necessary to compete with the academic hospitals and the larger system hospitals? I don't know. But those are the questions that we have to ask. The examples of that, we're on the threshold of some really, amazing things, great surgical technology, but are we going to be able to afford it? We're talking about hybrid operating rooms, virtual reality and augmented reality, image-guided tumor management. The OR environment is becoming getting a lot of scrutiny these days for infection rates, and that's going to strongly affect the viability of our operating rooms that we're using today. Communication and system integration systems, endoscopic surgery, robotics. Robotics is a big thing, obviously. This technology, these are the items of technology that we've had to acquire just within the last 3 years. And this is more, and probably represents more money than what we had spent on technology in the previous 10. These are very important, but if you look at the bottom, the one that stands out, certainly in our administrators' minds, is the robot. The problem with these things is that you have to purchase them. You have to have the money to purchase them. You have to have the cost to maintain them, to operate them. You have to store them. You have to train the doctors. You have to train the nursing staff and the techs. And our concern with this acquisition is that this is just what we had to acquire in general surgery. It doesn't take into account what the hospital had to acquire to support orthopedics, OBGYN, and urology. The robot is interesting. If you look at this map, this is robot installations in the upper Midwest region in 2010. It was approximately 29 robots at 21 different hospitals. And you can see that it's mainly clustered around Minneapolis and Rochester, which is not unsurprising. If you look at today, or 2019, we see that we're talking about 67 robots in 34 hospitals. And if you look at that, you'll see that a lot of that is occurring out in the smaller communities in Minnesota. Most of the communities in Minnesota are small, with just a few exceptions. Robot has made a tremendous impact on a lot of different hospitals. The number of system placements has risen by 75% in the last 3 years. The installed base has increased by 25% in that same period of time. If you look at these graphs, you see that in OBGYN, urology, and general surgery in particular, the use of the robot, number of operations being done, is significantly increased. So, to conclude, I think that advanced MIS, I think it's certainly been apparent to us that to some degree it's going to be mandatory for the growth, for the survival of a community surgical practice. And as knowledge and technology increases, it's going to be increasingly difficult to maintain eminence in any aspect of advanced MIS simply because of the ability to afford it and the ability to have the physicians that are capable of utilizing it. Community practices, I'm afraid, are going to end up at the mercy of healthcare systems which have broader financial reach and can afford the new technologies and the specialists to run them are available. And as we increasingly specialize, it's not just the technology that community practices are going to have to acquire, but it's also the specialists and also the techs, and it's the training that goes along with making sure that everybody can use that technology. I'm inclined to predict that there's going to be a greater tendency towards disparity in advanced MIS between the community practice and the system academic systems. The shift of specialized surgical techniques to system academic hospitals, the centers of excellence, is a concept that I'm afraid has already had some traction around the country, and I'm afraid it's going to get more. Community practice, I'm afraid, is going to be hard to keep up. This is my granddaughter. This is the surgical technology that she's grown up using. And I wonder now what kind of technology she's going to be using in 30 years when she's an advanced MIS surgeon. And where is she going to be doing that? Is she going to be doing it in a rural community? Or is she going to be doing it in an Ivory Tower Medical Center? I don't know. But I hope that she gets to make that choice. That concludes my talk. Thank you for your attention.
Thank you.